UCC, and we're really proud to have her back here now as a consultant medical oncologist with a specialist interest in cancer genetics. So Hazel has completed fellowships in oncogenetics, gynae-oncology, thoracic oncology, the Royal Marsden in London, so a massive centre, huge of experience there. And research interests include hereditary cancer predisposition syndrome, circulating tumour DNA, and oncogene-addicted non-small cell lung cancer. And she holds a master's degree in clinical trials and postgraduate certificate in cancer genetics. So this afternoon, she's going to talk to us on cancer genetics and Lynch syndrome. So Hazel.
Thank you for the introduction, Mark. Great. Can you see my slides?
Yep, perfect, Hazel. Thanks.
Brilliant. As Mark has said, I'm one of the medical oncologists here in CUH, and I'm specialising in cancer genetics as well as gynae-oncology and thoracic oncology. Here are my disclosures. So I have just 20 minutes, but I'm going to try and give an overview of Lynch syndrome, talk about the epidemiology, how we screen tumours for Lynch syndrome, how we manage patients with Lynch syndrome to prevent cancer, and also those who have a cancer diagnosis, how we treat them with immunotherapy. And finally, I'm going to talk a little bit about our cancer genetics service here in CUH. So Lynch syndrome is inherited cancer predisposition syndrome. And Lynch syndrome arises from a germline pathogenic variant in one of the mismatch repair genes, MLH1, MSH2, MSH6, or PMS2, or rarely due to inactivation of MSH2 due to deletion of the neighboring EpCAM gene. It's an autosomal dominant disorder, so the condition arises in the heterozygous state. And it's actually quite common, with population studies estimating that it's present in 1 out of 279. And carriers of Lynch syndrome have an increased risk of multiple cancers, with a 40 to 80% lifetime risk of cancer. But the risk of cancer varies with each gene, which in particular MLH1 variants have a high risk of colorectal cancer. Women have an increased risk of endometrial cancer, and also in particular we see more urinary tract cancers in carriers of MSH2 variants. And these are graphs from the prospective Lynch syndrome database, which analyzed over 6,000 patients, which accumulated to over 50,000 years of follow-up. And this is the cumulative lifetime risk of any cancer in carriers of pathogenic variants in the Lynch syndrome genes. And you can see that the highest risk for cancer is in the carriers of MLH1 and MSH2 pathogenic variants. There's also an increased risk in MSH6 variants. The highest risk is for those who are female carriers, and the penetrance of PMS2 is lower, and the risk of colorectal cancer and endometrial cancer is the most common cancer in PMS2 carriers. And below I've given the estimated prevalence of these pathogenic variants in the population, and actually PMS2 is the most common, present in approximately 1 in 714 in the population. And Lynch syndrome tumours have distinct characteristics. So Lynch syndrome tumours have mismatch repair deficiency and subsequent microsatellite instability. So the mismatch repair system is a DNA repair mechanism, and it corrects base substitution mismatches and small insertion deletion mismatches, which occur during DNA replication. And thus, and these DNA mismatches commonly occur in regions of repetitive nucleotide sequences called microsatellites. Thus, a characteristic of MMR deficiency in the tumours is expansion and contraction of these microsatellite regions, leading to microsatellite instability, or MSI. So the presence of MSI is a phenotypic evidence of the MMR system not working properly, and it characterises a hypermutable state. And so we can test for MMR deficiency or microsatellite instability in tumours as a screening test for Lynch syndrome. We can do that through immunohistochemistry. So the pattern of MMR protein loss on immunohistochemistry can give indication of the underlying genetic aberration. So actually the majority of MMR deficiency is caused by somatic mutations. So that's mutations confined to the tumor, and most commonly hypermethylation of MLH1, but of course can be due to inherited or germline mutations in Lynch syndrome. And here, this is an example of mismatch repair loss of MLH1 and PMS2 on a colorectal adenocarcinoma sample. And microsatellite instability, as we said, is a consequence of MMR deficiency. But microsatellite instability is common in multiple cancers. And this is a figure from the Cancer Genome Atlas showing the prevalence of microsatellite instability across 39 human cancer types. And you can see it's most frequent in endometrial cancers, with actually 30% of endometrial cancers having microsatellite instability, and 15% of colorectal cancers have microsatellite instability. But about 3% of colorectal cancers and 3% of endometrial cancers will have underlying Lynch syndrome. So how do we test for MSI? Well, usually that's with next generation sequencing or PCR, polymerase chain reaction. And in CUH, we use the ADILA biomarker test. And if there's 2 or more markers showing instability, a cancer is MSI high. If 1 marker shows instability, it's MSI low. And if it's MSS stable, if there's no instability seen in these markers. So we follow these diagnostic algorithms to screen a tumor for mismatch repair deficiency or microsatellite instability. And because of the high incidence of MSI in colorectal cancer and endometrial cancers, universal screening of all colorectal cancers, regardless of stage, and endometrial cancers, regardless of stage and age, are recommended to have MMR or MSI testing. In particular, MSI testing should be really limited to colorectal cancers, as it's less reliable than endometrial cancer at the moment. However, this is improving as the assays improve. And subsequent BRAF testing is only required for colorectal cancer patients. So if we follow these algorithms and it is deemed that this is not is likely a Lynch-related cancer, then the patient is then referred to cancer genetics for germline genetic testing. If someone has an underlying Lynch syndrome, how do we manage them? So if we see a man or woman with a new diagnosis of Lynch syndrome, or if someone's in follow-up a carrier of Lynch syndrome, we assess their non-modifiable and modifiable risk factors. So of course, their non-modifiable risk factors are their age, their gender, the gene that with the pathogenic variant, and their family history. And the family history is actually quite important. Studies have shown that the familial burden of cancer should be considered when planning a person's screening. So if there's a higher incidence of endometrial cancer at a younger age, for example, you might recommend risk-reducing surgery earlier in that patient. But there's also modifiable risk factors that a Lynch syndrome carrier can change. So there's, of course, the uptake of screening and surgery, which we'll talk about, but there's also chemo prevention, diet interventions, and lifestyle interventions. So Lynch syndrome carriers are recommended to have colonoscopy screening, and colonoscopies have been shown to reduce the incidence and mortality of colorectal cancer and Lynch syndrome. And in Lynch syndrome, the colon cancers tend to be often in the proximal colon, and actually the adenomas or polyps can often be flat, so non-polypoid. So high quality endoscopy is really important so that you don't miss a Lynch syndrome cancer. And because of the young age of onset of Lynch syndrome cancers, colonoscopies is recommended from age 25 in carriers with pathogenic variants in MLH1 and MSH2, and from age 35 in MSH6 or PMS2. But if a colorectal cancer has happened in an age younger than this in the family, the screening is recommended to start 5 years before the youngest colorectal cancer in an affected relative. But interval cancers has been found in patients undergoing colonoscopy screening. So there's some debate of whether these patients should be having colonoscopies more frequently than 2 years. But data from the prospective Lynch syndrome database has shown that reducing the interval of colonoscopy screening did not reduce the incidence of colon cancer. But why can that be? And that's actually because some colon cancers in Lynch syndrome skip the adenoma pathways, so they have an accelerated carcinogenesis, and they don't go through the polypus don't go from a polyp to a carcinoma, and that's why colonoscopy can is not effective at reducing these types of cancers. And this pathway is more common in MLH1 pathogenic variants, but can also be seen in MSH2 and MSH6, while in PMS2, the cancers tend to go through the adenoma to carcinoma pathway. And what about managing gynecological risk? So there's conflicting guidelines whether we should be doing endometrial screening, so that's ultrasound and endometrial sampling with PAPEL, and ovarian screening, so that would be with ultrasound and regular CA125, with the UK guidelines not recommending it, and with the US guidelines saying consider it. But at the moment, there isn't a good burden of it isn't enough evidence to show that it's efficacious. And what we do know is that risk-reducing surgery does reduce the risk of these cancers in patients. So risk-reducing bilateral salpingo oophorectomy and hysterectomies are recommended in MLH1, MSH2, and MSH6 carriers at approximately age 40. And with PMS2 carriers, you can wait till women are postmenopausal. But when we're counselling a patient about risk-reducing surgery, we really take in, of course, their desire for childbearing, their family history, and their gene mutation, as well as comorbidities, to give them a personalised approach. And what about screening for other cancers in Lynch syndrome? Well, previously urinalysis and urine cytology has been done to screen for urinary tract cancers. However, the sensitivity was really, really low. And actually, MSI testing of urine is currently being prospectively investigated. From the IMPACT study, we saw that prostate cancer screening with a PSA from age 40 has been shown to improve the detection of prostate cancer in these patients, and particularly in MSH2 and MSH6 carriers. With gastric cancer, regular OGDs is currently not recommended, but we do know that Lynch syndrome carriers with a Helicobacter pylori infection have a 20-time increased risk of gastric cancer. So H. pylori testing and eradication is recommended. With pancreatic cancer, we all know that screening for pancreatic cancer is under debate and can be considered for those who have a first-degree relative affected by pancreatic cancer. And then dermatological examination is not routinely recommended in syndrome. But if you see someone with sebaceous carcinoma, this is a rare carcinoma, but up to 1/3 of those will have Lynch syndrome. And these cancers should be considered for screening with MMR or MSI testing. Aspirin can be used as chemoprophylaxis in Lynch syndrome, and this is based on data from the CAP2 study. So in this study, patients are randomized to 600 milligrams of aspirin for at least 2 years or placebo. And at 5 years, they didn't see a reduction in the cancer incidence, but it's thought that the effect of aspirin is quite, the protective effects of aspirin is quite delayed. So after 10 years of analysis, they found that there was a reduction in the risk of colorectal cancer with a hazard ratio of 0.65. So aspirin at a dose of 150 to 300 milligrams is recommended from guidelines at ages from 25, but not over age 70, for 2 to 5 years in total. And the CAP3 study is currently ongoing, which is ascertaining the appropriate dose of aspirin and the appropriate duration. And we hope to have some results from that later this year or in 2025. But high-dose aspirin has some GI toxicity and can be hard for patients to take. And we know inflammatory bowel disease that 5-ASA or mesalamine reduces inflammation of the bowel. So maybe this could be uses chemo prevention Lynch syndrome. It has similar mechanism to aspirin on the COX pathway, but has less GI toxicity. So the MESOCAP study is investigating whether mesalamine can be chemo prevention in Lynch syndrome. And what about diet? Well, actually, fiber has been shown to reduce cancer risk in Lynch syndrome carriers. So another component of the CAP2 study involved randomizing patients to resistant starch. So that's resistant starch is a component of dietary fiber present in foods such as bananas, grains, pulses, and seeds. And patients were given 30 grams of resistant starch a day versus or a placebo. And after 10 years of follow-up, what the investigators hypothesized is that the resistant starch or the improved fiber would reduce the incidence of colorectal cancer. But actually, we can see in the top graph that there was no significant reduction in colorectal cancer incidence. But what they did find is that there was a reduction in non-colorectal cancers in Lynch syndrome carriers with a hazard ratio of 0.54. And this was particularly upper GI cancers and hepatobiliary cancers. And the theory for this is that resistant starch is fermented in the large bowel to short-chain fatty acids by the bacteria in the large bowel. And this reduces bile acids and is thought to benefit the gut microbiome. And of course, we know that there's increasing evidence that the gut microbiome is involved in immunoprevention and can affect, and improving the microbiome may help prevent cancers. In addition, there's been retrospective studies that found that those with Lynch syndrome who exercise regularly had a reduced cancer risk. And this is a graphic from a prospective study in MD Anderson, where patients with Lynch syndrome were randomized to intensive exercise. So 3 times a week they were encouraged to do cycling, or else they were randomized to usual care. And they did colonoscopies and blood tests at the beginning and the end of the intervention. And they found those who exercise regularly had a reduction in inflammation and and this is being further followed prospectively. So intervention may be, exercise may be preventative against cancer in Lynch syndrome patients. So when we counsel a patient in our clinic with Lynch syndrome, we use the UK Cancer Genetics Group guidelines, or UK CDG, which have guidelines tailored to the pathogenic mutation. And we also take into consideration the patient's personal risk factors as well as their family history. And also the prospective Lynch syndrome database has this interactive website where we can put in the patient's age and the organ involved and their pathogenic variant, and give them a risk of cancer for each organ with 95% confidence intervals, which are very useful when counseling patients. Now, back to MMR deficient tumours. So as we said, 30% of endometrial cancers and 15% of colorectal cancers are MMR deficient, and a proportion of these will have Lynch syndrome. And this is data from 2015 that show that heavily pre-treated patients with advanced cancer who are MMR deficient had responses to mismatch repair, had responses to immunotherapy or PD-1 blockade. And this led to the FDA approving pembrolizumab regardless of disease site in 2017. And since then, the EMA has approved immune checkpoint inhibition for MMR deficient tumours with colorectal cancer, endometrial cancer, biliary tract, small bowel, and gastric. However, in Ireland, we currently can only access immunotherapy for MSI or MMR deficient colorectal cancers, with reimbursement for endometrial cancer currently awaited, and there's no access for other MMR deficient tumours, unfortunately, in Ireland. And as we know in oncology, if something works in the metastatic setting, we try to see if it can work earlier in the disease course to try and improve our cure rates. And this was data from the NICHE 2 study, which was initially presented in ESMO 2022. We had the disease-free survival in 2024. And this was a really exciting study where they treated people with advanced MMR deficient colon cancer with 2 cycles of immunotherapy, and then they went on to surgery. And we know if we treat these patients with standard chemotherapy, that the pathological or the response rate is about 7%. But actually, the pathological response rate in the NICHE 2 study was 98%, with the complete response rate of 68%. And the 3-year disease-free survival has now been updated, and it's 100%. So there's now more larger studies assessing whether this can be used in the first-line setting, and there's phase 3 studies ongoing. Similarly, with rectal cancers, a component of these patients are MMR deficient, and we know that the surgery for rectal cancer is quite debilitating. And there's a lot of studies investigating that if those who have a complete clinical response, whether you can follow them up clinically and avoid surgery. And this was a phase 2 study of just 12 patients who were given immunotherapy for 9 doses neoadjuvantly, and they had a 100% complete response rate. So again, this is being investigated in larger prospective clinical trials. And what about using immunotherapy for cancer prevention? So using it even earlier or in Lynch syndrome carriers. So as we've described, Lynch syndrome tumors have a predictable mutation pattern, and they these tumors are hypermutated. And it's been shown that Lynch syndrome carriers with no cancers have these neoantigens present. And these vaccines are in development to target these neoantigens. And a phase 1 study from Heidelberg has shown that a frame shift peptide neoantigen-based vaccine is safe. So there's now numerous vaccines under investigation to prevent cancer in Lynch syndrome carriers. So as Mark has discussed, cancer prevention and cancer genetics and prevention is one of the priority programs here in UCC and CUH, and Mark is leading that. And he is he was very important in developing the cancer genetic service here in CUH, which I'm a part of, but also is being led by our principal genetic counsellor Marie Duff, our visiting clinical geneticist Anand Sagar. We also have our data manager Hilary Lottie, who's very important that we prospectively collect this data, and we have a wide MDT team. Vicky Cleary is one of our candidate AMPs who runs the risk-reducing gynae oncology clinic with Zibi Marchocki, and we also now have access to psych oncology for our our cancer genetics patients. So what's next for cancer genetics? Well, in Ireland, we know that the NCCP are prioritising cancer genetics, and the NCCP Hereditary Model of Care was published in 2023. And the next step is to roll out mainstreaming. So mainstreaming involves bringing cancer genetics testing even earlier in the patient pathway. So the medical oncologist or the surgeon or the gastroenterologist can send the patient patient's blood or DNA for a germline test to look for Lynch syndrome if they meet the certain criteria. And this means that not all patients need to see cancer genetics, and it speeds up the diagnostic pathway for these patients, and this will lead to more patients and their families having genetic testing earlier. And then the patients with pathogenic variants or VUSs or complex family histories are then referred to cancer genetics for counselling. And as we know also in Ireland, the health electronic records are quite fragmented, and I think we need to copy the UK and England and have a national registry for Lynch syndrome, and an example of that is the Lynch Registry England, where they collate somatic results, germline results, to identify trends in disease. And national registries are very important for our Lynch syndrome patients so we can improve their outcomes, and also for research collaboration. So in conclusion, Lynch syndrome is a common multi-system disease inherited in autosomal dominant patterns. And there are effective risk-reducing interventions that are medical, but also lifestyle interventions. We should offer our patients personalized screening based on their genetic risk, but also their personal risks. We can now offer patients with mismatched repair deficient tumors personalized oncological therapy. And for effective management of Lynch syndrome, we need coordinated care and pathways for our patients. So thank you for your attention. If you have any questions, I'm happy to answer them.
Hazel, that was great talk. Thank you very much. And really exciting, actually, isn't it? I mean, it's great to see that, you know, we're moving to a space where we can be cutting out the surgical oncologist and the medical oncologist by preventing all these from happening in the first place. So I think we'd all like to be quieter. So I know there'll be lots of questions for you shortly, but we're going to go to our next speaker first, and then we'll wrap back around then with the questions people have. So our next speaker is Jacqueline Daly. So we're really lucky to have Jacqueline online with us today. So Jacqueline, we've not physically met, but I'm familiar with the work you've done over the years. And Jacqueline really has a unique perspective as a patient advocate who is also seeing cancer affect some of her closest family. And Jacqueline's the vice chair of the Cancer Patients Europe and CELTA. Are very fortunate to have her as a member of their Cancer Network Advisory Board. She's a member of the Cancer Trials Ireland Patient Committee and the National Cancer Research Group for the NCCP. And she's active on multiple levels, both nationally and across Europe, articulating and advocating for people with cancer. Despite all of this, Jacqueline somehow still manages to find time to provide complementary therapies to people who need them. And I suppose, look, in an era globally when our population is expanding, we often unfortunately see that our sense of community is diminishing. And really, I mean, Jacqueline's been a huge contributor to our community. And I think when Hazel ultimately picks up her Nobel for figuring out cloning, I suggest we probably start here. But Jacqueline, you're going to talk to us now this afternoon about the importance of community cancer support centres. So thank you.
Thank you, Mark, and thank you for the opportunity to actually talk about cancer support centres in the community. And I have a real belief that real healing happens in community. The hospitals do amazing work, all the researchers, amazing work. But sometime out of that hospital setting, you actually need the support of cancer support centres. Now, in Ireland, we have a huge network of support centres, and we are now have formed an alliance under the NCCP, which is excellent because what it actually does is make sure that we're all working at a very high standard and that whatever we're doing is the best for the patients. So at East Galway Midlands Cancer Support, it was started as a prostate support group around our kitchen table when my husband had been diagnosed with prostate cancer, and we discovered that there wasn't a lot of help and support in the community. So people started coming to our house asking for support, and again, just people sitting together. We were very lucky that one of the oncology nurses in Portiuncula Hospital joined us, and together with Professor Eamon Rogers, we started to form this what is now our support group. So what we do is we provide a network of emotional, psychological and practical support for people living with cancer, their family and friends. And quite often in that whole cancer journey, the family is forgotten about a little bit, and friends are also can be very, very deeply impacted by a cancer diagnosis. So we will look after the whole family. So we also will take a close look at the unmet needs. Again, when you're talking about the hospital, there's only so much a hospital can do. So at the centre, we provide the very welcome cup of tea. It should never be underestimated. So one of the things that I would do here on Wednesday, I go down to Portiuncula and I will go into the clinic and I will go and I'll talk to the patients that are having their chemotherapy and see if there's something extra, something, you know, that they're not being, that'll be an entitlement. Maybe there's a family member at home that's really struggling. So we can identify very early what needs to be put in place. So we have a picture here of one of our counselling rooms. So we have 11 counsellors here at the centre. And again, the counselling is, we tend to do clinical need rather than to give, you know, 6-7 sessions and then say you're fine. So where possible, we will always do clinical need. We will also do the counselling for the family members. We run a programme called Climb. That's a programme for children who have an adult in their life with a cancer diagnosis. So it's done over 6 weeks and it's done through art and drama. Again, this programme is not for somebody with metastatic disease. This is for somebody who's going to have a reasonably good outcome. We also offer the service of writing for the future. So we would sit down with somebody who has got a bad prognosis and they may want to leave some letters or even form a book with photographs for family members that are left afterwards. And the reaction from that, from the families afterwards, is always just, it's so humbling. It just means so much to the family. And of course, if you are scribing something like that, you have to write it exactly as it said. So quite often what we would hear from the family members is, oh my God, it sounded like they were talking when I read that. That's exactly what you want. So as Mark said, we do a whole host of complementary therapies as well. So we do reflexology, Reiki, bioenergy, healing touch. Again, all of these are there, Indian head massage. These are put in place to actually make the journey a little bit easier on the patient. So if you're having nausea from chemotherapy or you've got, you know, some skin irritation from radiotherapy, we'll try and set a time, you know, an hour aside for you where you have something really nice done just for you, and it's got nothing to do with cancer. It's just about being nice to yourself. One of the newest things, this chair you see with the blue seat, it's called the Amsella chair. So we use that chair for, it started off actually for prostate cancer patients who were having trouble with incontinence. We've now discovered that it is so valuable for anybody with a pelvic floor cancer where may have a problem with incontinence. And it's non-invasive. You sit on the chair for 28 minutes. Chair does all the works. It's the equivalent of 11,000 Kegels in 28 minutes. So there's no way any person is going to be able to do that on their own. Now, there is a criteria. So if you've got heart conditions and that, there are criteria that you have to meet. So it's not safe for everybody. So we're very, very strict as to who uses it. We also have, you can see the bus here. We bring patients into Galway every day for their radiotherapy. And that takes a huge burden of people trying to, number one, fill your car with petrol or diesel. You've got tolls, you're trying to get into the hospital. I don't think there's a hospital in the country that isn't a nightmare trying to find parking, where we can drop the patients right outside the door of the radiotherapy department. When they're finished, they're back onto the bus and they're back here about lunchtime, and we have a meal ready for them if that's what they want. If they don't want to sit at the table with everybody else, they have the choice of bringing that meal home and having it in the comfort of their own home. We also are very lucky. We have a gym that once upon a time in a past life was a horse stable, but it's now our gym, and we run some research programs with UCHG as well, and that's the Can React program. We also do yoga. We have a walking program. So we've lots of different programs there that we hopefully, try and tailor it to meet each person individually. Of course, our very close working relationship with Portiuncula is the mainstay. And I did talk about going down once a week. I meet with the nurses and with the patients. We're all very proud of Ballinasloe to say that Portiuncula is the oldest nurse-led oncology unit in the country. So it's 23 years running. The other thing that I think that is quite often missed is that the value of nurses. Quite often the doctors have got limited time to spend time talking with patients. There's a whole queue waiting outside. And from our experience, quite often the patient will probably open up more to the nurse. So nurses are so valuable in this whole journey of cancer. It's really is incredible. And again, without having that close working relationship with the oncology unit, I don't think we'd be as effective as we are here. One of the things we do as well when a new client comes to us is get all our paperwork done, and then we will write back to the consultant and say, this patient has been, and these are the complementary therapies, or these are the interventions that they'd like to have. So unless we get confirmation from their oncologist that this is okay, they're happy for them to have it, we actually don't do any of the complementary therapies. So the one thing we can't lose track of is it has to be safe for the patient the whole time. So I suppose my take-home message today is those who say it can't be done are usually interrupted by those who are doing it. Do your little bit of good wherever you are. It is those little bits of good put together that overwhelm the world. And if it doesn't make it better, just don't do it. Thank you. That's just a little look of our garden, which we also use as a walking track.
Jacqueline, that's fantastic. Really, really enjoyed that talk. Thank you very much. And I suppose, you know what I'd say as well, certainly from our experience of the Cancer Centre, we just couldn't run cancer services without the support of the community cancer centres. I mean, they really have been such an enormous support to us. But I think we've a couple of questions in the chat function just before we get started into them. Hazel, can I ask you one thing? I mean, one of the biggest challenges that certainly I feel from a cancer genetics program is translating the knowledge of identifying that risk into an action of actually preventing a cancer. So handing over the knowledge that you're at risk to somebody, and then effectively being able to give them the tools to modify that. I mean, what are the tangible actions that you advise patients currently with, say, Lynch? You've addressed some of them, but how are they different now to, say, 5 years ago? And what do you think the next 5 years is going to bring?
So I suppose now we have more data on the benefit of aspirin. We didn't have that 5 years ago, so we can talk to patients about that. And we have the evidence of diet that we didn't have before, and exercise. So it's really important to tell patients that they have some control over their risk in those modifiable risk factors. And then really what I try to highlight is that they need to engage with their screening. So that's the colorectal cancer screening. What we find is that often people engage really are really motivated at the beginning, and then they kind of forget about their risk. So checking in and having dedicated Lynch Syndrome clinics where you can check with people to make sure that they're engaging with their recommended screening is important. In the next 5 years, I don't know how close vaccines are. They've been talking about them for a long time, so it's probably a lot more than 5 years away. But probably what will happen more in the oncological space is that they're investigating immunotherapy adjuvantly. So if someone has a mismatch repair deficient node positive tumor at the moment, we recommend adjuvant chemotherapy, but they're investigating, for example, the ATOMIC study, whether we could leave out chemotherapy and just go for immunotherapy. So that would have potentially less side effects for the patient. And also there is some possibility that the immunotherapy could prevent other cancers in these patients as well. So having benefits beyond just the primary cancer.
It's really exciting, isn't it?
Yeah.
It's a space that's developing as you watch it, really.
Yeah.
And it's one that from a Cork perspective and a Southwest perspective, we're really keen to be involved with too. So again, I'd stress I realize we've got a huge amount of people watching from the university side of things. So if there are opportunities that you see for collaborating with the Cancer Centre and vice versa, don't sit on them.
And to add to that, so there is some studies in other centres about testing the microbiome of these patients, so following stool samples serially to see if you can, and then seeing if there's any correlation between findings in colonoscopy and what they find in the stool and the microbiome, and then also circulating tumour DNA. So we know that we can there's these multi-cancer early detection studies that are assessing, using ctDNA for screening in populations, and in particular high-risk populations like Lynch, or for example, other cancer genetic predispositions like syndromes like BRCA, whether circulating tumor DNA can be used to detect these patients. And then actually lastly, Kevin Monaghan, who's a gastroenterologist in St. Mark's in the UK, who's actually originally from Galway, he's investigating whether FIT, so that's stool testing for fecal occult blood, with the FIT testing, whether we can use that in between colonoscopies for patients with Lynch syndrome to detect cancers as well. So there's loads and loads going on that are potential risk reducing interventions that are, relative. Some of them are inexpensive, and obviously some of them are a lot more translation as well.
Yeah, and I'm looking down the list of attendees today. I see lots of names there with lots of experience in a lot of those areas. So it'd be great to start seeing how we can really collaborate on that. So, I mean, Jacqueline, Susan Walsh has put a question into our chat. Susan Walsh is our advanced nurse practitioner who's done an enormous amount of work and an incredible job in setting up our high risk and moderate risk program for those at risk of breast cancer. So really, really paving the way and producing a national model. But she's just asked here about the Can React program. So it sounds like a fantastic initiative. Is there much uptake for it, and what are the unmet needs?
The Can React is actually a really fantastic. What I think the beauty about it is because it's personalized. So like when the patients come here, there's ECGs done, their bloods are done. There's complete follow-up. So they've got a choice to actually come in here to the centre and do their exercises here. If they have to travel for any great distance, it can be done over Zoom. So, when people have that option, it's really, really great. The other thing that most patients tend to like is to have somebody else working with them. So like if there's a group of them, it's really good. And then the beauty is the fact that we see the patient at the very beginning once they've been diagnosed. And we can start talking straight away about all of these interventions. So from the very beginning, we're talking about the exercise, we're talking about nutrition, we're encouraging them to get involved in the Can React program. So the uptake here has been really, really good. And out of that, I know that Mayo and Sligo have also started to run the program there. So it is absolutely spreading. So it's fantastic.
Yeah, it's great to see. It really is. And just Norma Relihan, who was one of our surgeons here in the CUH, or breast surgeons here with a big interest in genetics, has put a question in there. Just Hazel, in terms of IHC testing and next generation sequencing for Lynch, is that standardized across the country in all pathology departments? A bit of a controversial question, and Norma's great at controversial questions, and she's right. This is a really issue.
Yeah, it should be. I don't know if it is everywhere. So for example, because mismatch repair deficiency and MSI testing has treatment implications, usually in the metastatic setting. Some centres previously were just doing it on stage 4 or advanced cancers, or only doing it if the oncologist asked for it. Now all endometrial cancers and colorectal cancers should have it. But for example, in CUH, we only started doing it on all colorectal cancers in the last 24 months. It was done on the advanced ones prior to that, but we've been doing all our endometrial cancers for I think over 7 years. So we've been kind of ahead of that for a long time. I don't know if it's being done in all centres. I think it is by now, but I don't know how long it's been going on for. And to add to that, there is suggestions now that we should be doing it in all gastric cancers, which we're not, and whether we should have. So I think what's coming down the line, so John Burns Group, I think they're based in Manchester, they're actually looking at a next generation sequencing assay, which would be a bit easier because a lot of these samples undergo sequencing anyway to look for BRAF mutations or RAS mutations to guide therapy. So they're looking at an assay that can do the MSI and do the subsequent BRAF. So then patients don't, instead of following these diagnostic pathways, they're all done at the same time. So to streamline the processes. So those kind of tests are being validated at the moment. So in the future, we probably won't be doing IHC. We'll probably be doing sequencing for all of these, and all the biomarkers will be on one test, but that's a while away yet. So I think there's more to do, Norma, and I think the NCCP are trying to improve that. So there's quite a few working groups on mainstreaming and somatic testing, because once the somatic testing has to be properly done to feed into mainstreaming, so that all these patients are being screened for Lynch syndrome, but all these and also these patients are having the appropriate stratifying to the appropriate treatments. Because, for example, we know that M4 deficient colorectal cancers, if they're early stage, do quite well, and they don't need oxaliplatin based chemotherapy or 5-FU. So there's different. We need to kind of personalize patients' treatment based on their M4 status.
Yeah, really important question though, isn't it? I mean, you know, for a country of our size, Hazel, I mean, there's a huge amount of power in making sure that we're standardized in what we do and the approach we take. We really should be all over that. And actually, as a follow-up question, Norma has put in too, in terms of something that we've touched on a good bit too in our own program is, I mean, what do we need to do better at an undergraduate level to educate our nursing students, our doctor students, our allied health students, all these who are coming through university in terms of cancer genetics? Are we doing enough? I think the answer to that is obvious, but what do we need to do?
So I think, well, we've tried to, we need to see what this curriculum is at the moment, but I imagine that students are learning a lot about the kind of scientific component of it, but maybe not the clinical applications. So I think making sure that the pathways followed on from not just the implications on the screening of family members, but also the kind of ethical components of genetic testing, and that kind of discussion with patients. So there probably needs to be dedicated modules for cancer genetics in nursing and medical students. And there's quite a few postgraduate courses available in Ireland now, and the NCP are working as well to have some learning pieces for clinicians and nursing staff when mainstreaming is rolled out as well.
I think the little bit of free time you probably have, I can see diminishing pretty quickly over the next few years. Jacqueline, can I ask you a question as well? I mean, I suppose in my opinion, historically, we haven't done a great job in marrying together the work of the community and the cancer hospitals. Not because of anyone's particular fault, it's just because they haven't been aligned, really. My sense is that the new regional organization, here it's headed up by Andy Phillips, the REO, I mean, that has aligned community and acute hospitals will help this. Well, what are your thoughts on this, and how do we do that better? Because I think we should.
Absolutely. And of course, the more we talk to each other, the more we see what each other are doing, the better. There's a huge value in having, where possible, the consultants can actually come to the centres, talk, see what's going on. And I think to build those relationships are incredibly important all around. You know, that people come as a whole. You don't just come as a cancer, you come as a whole. So we need to be looking at the whole treatment holistically. So that's where, you know, even sitting down for the cup of tea is so important. And actually, even with Susan asked another question, I didn't finish her question. She asked about the greatest unmet needs. One of the things that we actually would see is that sexual function for a lot of people is not spoken about. So we have to look at the quality of life. It's not just the neuropathy in the feet and the hands. It is all of the quality of life, because cancer affects relationships as well. So that, again, it brings in that psychological support. So the more that we work together and talk to each other, I think the better the outcomes will be.
Yeah, no, I couldn't agree more, Jacqueline. I mean, it's interesting, isn't it? I mean, I know in some way, historically, we've treating cancers for probably thousands of years and attempting to do it, but really only in the last 100 years has it kind of developed. And I suppose we're still in its infancy in one respect, but there's 3 phases of the cancer treatment. There's the part when before you're diagnosed, the part when you're diagnosed, and then the part after you're treated. And we've focused almost exclusively for many years on the middle bit. I know we were now beginning to focus on the survivorship bit. I mean, Josephine Hegarty's done a huge amount of work with the in the university on this. It's been super to see, and it's great to see that developing and expanding. And now that bit before someone is diagnosed, that prevention bit is the bit that we need to also start focusing on as well, because it's just not going to be, it's not, as mentioned, it's not sustainable or ethical to be focusing all the time on the middle bit. We have to do either side. So I couldn't agree with you more. And I think actually, my sense with the new regions is that this will help that, because for many years community has been following one path, acute hospitals another path, and we just haven't had the opportunities to mix as much as we are now. I found that certainly in the last few months there's been an enormous amount of opportunities to mix with people, and the more you look, the more you see everybody's doing, and the more you see that actually they're doing quite similar to what we're doing, and there's synergies there. So yeah, no, it's great to see. I think, and thank you to all our speakers for staying on time. I think we're actually probably there. If no one else has any other questions that they want to quickly put in, I think really we can probably come to the end of the session a little bit ahead of time. I promised we'd get everybody finished on time, so I think finishing it a little earlier. I'm happy to take a gold medal if anyone's offering it, but it was a really good session. I really enjoyed it. And just looking ahead, the next session is on December 9th. Two really good speakers again, Rebecca Wong and Martin Higgins. So again, I'd certainly be looking forward to that. And then in the meantime, thanks everyone for your attention, to our speakers for really some fantastic talks and for keeping so well to time. And again, for people to participate. And for Emily for keeping me on the straight and narrow. So it's lovely seeing everybody, and enjoy the rest of your day.